is Meghan Filson. I am an OMS 4 at VCOM Auburn, and I wanted to talk a little bit today about a condition called Usher syndrome. So Usher syndrome is an autosomal genetic condition. Its estimated prevalence is actually 0.004% in the United States. There's 3 subtypes, cleverly named Usher syndrome 1, 2, and 3. And these 3 subtypes are differentiated mainly on first the genetics, so the genetic that actually causes it, and the actin filament specifically associated with that. If you see figure 1, that kind of shows where in the sensory cell each one of these Usher 1, 2, and 3 are affected. It's also differentiated on the characteristics. So it's characterized by sensory neural hearing loss and retinitis pigmentosa. So the onset of these in each 1, 2, and 3 are different. So for example, Usher 1 will be born with severe to profound sensory neural hearing loss, and the retinitis pigmentosa will have an onset in early adolescence. Whereas in Usher syndrome 2, they'll have mild hearing loss, and the retinitis pigmentosa will actually present in early 30s. So that leads a lot to why they think this condition is largely underdiagnosed or misdiagnosed as non-syndromic deafness, is because a lot of these patients are actually not realized to have Usher syndrome until later on in their life. It's actually believed that this is the most common genetic explanation for combined hearing and visual loss, accounting for approximately 50% of patients younger than 65 years old, actually. And so going into the clinical presentation a little bit. So the chief complaint we had coming in is a newborn who failed her newborn hearing screening in the nursery, which a lot of you know is not actually a big deal because a lot of newborns actually fail their hearing screening in the nursery. It does a lot with there's a lot of other sounds going on, the babies are moving. So this is common, and it's just recommended that they follow up with their pediatrician in 1 month to repeat this screening. So they follow up for a newborn screening, and actually the parents start reporting that the baby's not responding to the dog is barking, and she's not really responding to her name or moving her head like they had seen with their older child. Additionally, she did present later on, around 4 months, she wasn't able to meet her developmental milestones of being able to roll, and at 9 months, she wasn't being able to sit upright without support. And that kind of goes into how we got a genetic consultation. So our patient was actually a healthy newborn female. She didn't have any traumatic vaginal birth. She was born at 39 weeks, no labor complications. Her oxygen saturation was 97%. APGARs looked good. Family history, mom was a G2P1, uncomplicated pregnancy, no viral or bacterial illnesses reported. She was rubella immune. And then on physical exam, this child was actually normal cephalic, so no head trauma. Red reflexes looked good. Otoscopic examination was fine. Really unremarkable overall. And so with a lot of that, we were trying to rule in or out intrauterine infections such as rubella, CMV infections, potentially hypoxia and prematurity. Any anatomical abnormalities, or mom using ototoxic drugs, which all ended up being unremarkable. So that kind of led the physician I was working with to kind of start getting some more testing. So at 1 month, she ended up getting her newborn hearing screening again, and she ended up failing that. And due to the clinical presentation, the physician I was with decided to go ahead and consult ENT. So ENT saw her and ended up doing a normal high frequency tympanogram, which, if you don't know, kind of tests if the middle ear is conducting properly. And she ended up passing that. So her middle ear was fine. There was no conductive hearing loss at all. So they ended up moving on to an auditory brainstem response, which actually tests cranial nerve 8 to see if it's responding to the brain and the brain is sending signals back, basically. And they confirmed that she had bilateral severe to profound sensory neural hearing loss. Based on this and really no other presenting symptoms, they advised that we go ahead and get a genetic consult. And so around 9 months old, so we saw her kind of continually failing her developmental milestones. Finally, at 9 months old, we were able to get in with genetics. and we found that she had a mutation in the MYO7A gene, which is directly linked to Usher syndrome type 1B. So really going from here, the management of these patients, a lot of them either need hearing aids or cochlear implants, and these kind of need to be established early in the child's life because they need to start developing speech and just to help them actually progress with their milestones, as well as they need an ophthalmology consult because we need to start early assessing the retinal degeneration, as well as they kind of have cataracts and a tendency to get macular edema. And so I kind of showed in figure 2 a little bit of the pictures of what retinitis pigmentosa kind of looks like in the eye. On the left, you see a normal eye, and then on the right, you see what the board term is as bone spicules. And it's just these clumps of pigment that start collecting. And I kind of want to talk about like how significant this is for the parent as well as the child, because the child will start to develop night vision loss, photophobia, blurred vision, and it'll eventually go to tunnel vision. So it is traumatic, honestly, for the child as well as the caregiver to be consulting them about this. Also, they are going to need a neurology consult because these children are at a tendency to have vestibular dysfunction on top of the more prevalent inner ear dysfunction. And that kind of came into why our child was specifically failing her 4 and 9 months milestones. They're going to need physical therapy due to the vestibular dysfunction, as well as speech therapy. And just going in again and reiterating that they do need mental health support. They actually found that there was a lot of depression and suicidal ideation in these patients, as well as the caregivers. The caregivers actually were found to have a lot of caregiver guilt. So to conclude for my discussion, for patients with congenital hearing loss, Usher syndrome should be considered on the differential, especially if there's no other identified cause. Severe physical and developmental deficits will transpire without treatment. So it's just imperative to kind of have a little bit of awareness of this, potentially keep it on your differential. I'll take any questions at this time.
Alrighty, Megan, thank you so much. So you kind of ended with, catching this early, getting treatments. So are we normally catching this pretty early on? Is this kind of part of a screening when we have kind of neonatal deafness?
So it's not actually part of screening. It's something you actually have to you have to consult with genetics for follow-up. And that's largely, specifically, Usher syndrome type 1 has a higher probability of being diagnosed because the sensory neural hearing loss is early onset, as well as retinitis pigmentosa. But like I said earlier, with Usher syndrome 3, like these people have mild hearing loss. So they're like kids who might need hearing aids. So it might be suspected that they have another cause, like they might have had, hypoxia, which could have resulted in some kind of hearing loss or some kind of head trauma, something else that the physician might contribute to their hearing loss until they get into their late 20s, early 30s is when they'll start to develop the retinitis pigmentosa, which might or might not prompt a physician to potentially get genetic counseling.
And what are some of the interventions that are done to kind of prevent some of the worst sequelae?
So the biggest thing is actually intervening with the hearing. So using the cochlear implants first off. And then a lot of times, really the retinitis pigmentosa actually isn't preventable. A lot of times the ophthalmologist just have to, from my understanding of it, a lot of times the ophthalmologist just has to monitor. And initially it's recommended that they get in with ophthalmology around 1 year old, just because they can get a baseline and understand how fast it's going to progress and be able to give the patient as well as the caregiver like an approximate time of, because these patients will eventually go blind.
Gotcha.
As far as it's just physical and speech therapy. So physical therapy needs to really work on ataxic gait and just being able to balance, as well as they're going to be really a big proponent in being able to get these children to develop their motor milestones.